Hi, my name is Michelle Armstrong. I'm a nurse practitioner here in Memphis, Tennessee at Methodist Hospital. I work predominantly in malignant heme currently, but do have experience with bone marrow transplant and cell therapy. Today, we are going to be discussing cytokine release syndrome and immune effector cell associated neurotoxicity syndrome. We'll touch on the mechanism, assessment of those syndromes, clinical manifestations, grading, and management. So first off, what is cytokine release syndrome? It is a systemic inflammatory response triggered by immune therapies. This inflammatory response is predominantly triggered by the release of IL-2, IL-6, and the symptoms can range from mild to life-threatening, requiring immediate attention. The onset can be variable. It can occur within hours after infusion or more than a week after the infusion of cells. In my experience, most of the time, if they're going to have any of the CRS toxicity, typically it likes to happen about 12 hours after infusion of the cells, but of course, there are always the outliers. I have seen as soon as you infuse the cells, it's occurred, and then 4 or 5 days later. The risk factors include age, tumor burden, and comorbidities. One thing that has been developed over time is a way to kind of predict if a patient is at high risk for developing CRS after the infusion of cells or any of the therapies. It's called a modified E6 score, and it uses labs, LD, CRP, and your platelet count of the patient to determine what their risk factors are, if they're going to be high risk for developing CRS or not. It's basically a marker of endothelial damage, which translates over to the risk of developing CRS. So what causes CRS? There's a plethora of things that can potentiate this cytokine release syndrome. Most commonly known are CAR T cell therapies like Kymriah, Yescarta, Breyanzi, Tecartus, Abecma. Sometimes monoclonal antibodies like Rituxan, Blincyto, those have more mild CRS potential. Immune checkpoint inhibitors, and then one of the newer therapies that's really being heavily developed, BiTE therapies like teclistamab, Tekelvi, they do have the potential for some of the more severe CRS type reactions. Others are adoptive T cell therapies, interleukin therapies, stem cell transplant. After an allogeneic stem cell transplant, patients do sometimes have more mild CRS type symptoms. And then, of course, infections and sepsis. During COVID, a lot of what was in the media with the more severe COVID diseases and those that led to more toxic and bad side effects, even death. CRS was a lot of the leading causes of that, with the fever and everything else. So, assessment of CRS. Of course, you're going to include a physical exam, which is going to have vital signs every 4 hours. Unless CRS is detected, then you would want to increase your vital signs to every 2 hours. A daily weight, intake and output, daily labs to include CBC, CMP, magnesium, phosphorus, uric acid, LD, PT, PTT, fibrinogen, D-dimer, ferritin, and CRP. CRP is particularly important because as you watch it increase is when you become more concerned that CRS is starting to develop, and that you should be really, really monitoring your patients for fever, any kind of lab signs that, with the kidneys, as far as if they're going to be having any organ damage. And then we'll get into it later on, but to determine if they're going to have what's called ICANS, confusion, and so forth. With these patients, telemetry monitoring around the clock is recommended. Of course, that's going to depend heavily, and a lot of this honestly is going to depend heavily on if you're doing this on an inpatient or outpatient basis. And the outpatient administration of these therapies is really starting to become more popular, largely in part because of the cost related with these. And so the longer you can keep these patients out of the hospital, if possible, the more cost efficient it can be. And so that would, hopefully make these therapies more widely available over time to the general population. A pulse oximetry would be included as well, 24 hours, or if you're on an outpatient basis, just spot monitoring. So clinical manifestations of CRS. Fever, that's going to be greater than 38 degrees Celsius, is the most common symptom. And that is typically the one that you see patients develop about 12 hours after the infusion of cells or the administration of whatever therapy may be. Hypotension with a systolic blood pressure less than 90, hypoxia with oxygen saturations less than 90% on room air. Organ dysfunction can occur, and that's going to be predominantly seen in the liver, kidneys, and lungs. And then neurological symptoms can appear, linking immune effector cell associated neurotoxicity syndrome. And like I said before, you're going to really want to monitor these symptoms, but each program, and it's going to be provider specific, is going to develop a system of monitoring, whether it be inpatient or outpatient, to allow for the safest overall administration of these therapies. If you're outpatient, sometimes aside from the daily check-ins when they're coming into clinic and you're getting lab work and the full assessment, including vital signs, then a lot of times providers are offering spot monitoring at home. And those can sometimes be uploaded to your charting systems and be a good way to really track fever, heart rate, and oxygen saturations while these patients are at home. And then sometimes these systems are advanced enough to be able to really flag the providers, whether it be through a electronic notification system that goes directly to their phone, or everywhere's going to have a different protocol. But then it flags the providers, and you can ask them to go ahead and come on into the emergency room and get them taken care of that way. So that's one of the big developments as far as being able to keep patients out of the hospital longer and be able to do this safely. So grading of CRS. The grading is going to be very important because the grading is what guides your treatment and your response. And then of course, your further workup. So grade 1 is always going to include fever. Fever is greater than 38 degrees Celsius. No additional symptoms along with fever, just fever. So otherwise vital signs are stable. Of course, you want to monitor if these patients have had any type of Tylenol or steroids or anything within the last 24 hours to determine if this is, true fever or anything that could be potentially masking fever. So we really try to avoid Tylenol in these patients. So if they're needing pain control, using pain medications that do not have Tylenol is recommended. And then of course we attempt to limit steroids in these patients as much as possible unless absolutely needed for treatment of cytokine release syndrome. Grade 2 is going to be temperature greater than 38 degrees or equal to Celsius, and then either a low systolic blood pressure or a drop in oxygen. Now, this cannot be as severe to require pressors, and it can only be limited to a drop in oxygen that would be resolved with just low flow nasal cannula. So a binasal cannula between 2 to 6 liters. Grade 3 escalates to where you're going to require pressors to resolve the low blood pressure. So again, it's not going to respond to just IV fluids, for example. And then high flow nasal cannula could be required a face mask, a non-rebreather, or a Venturi mask. Grade 4 is going to be fever with low blood pressure that requires multiple pressors, and then oxygenation support that goes as far as CPAP, BiPAP, intubation, or mechanical ventilation. So management of grade 1. So as we saw in the last slide, grade 1 is just basically fever. This is when you're going to have a patient, 9 times out of 10, what happens is you've infused cells, you've given therapy in the daytime, and then 12 hours later in the middle of the night, the nurse or monitoring system alerts you, hey, this patient has a fever, it's greater than 38 degrees. So first and foremost with these patients, if they're at home, you're going to say, please go ahead, let's come on to the emergency room. And ideally you have a system set up with your facility to where they're aware that these patients exist, they have a plan in place, and they know to really prioritize these patients because they can go south quickly. So first, inpatient or outpatient, you get them to the facility if they're not inpatient, and you start a full sepsis workup. So blood cultures from central line and peripheral, a urine culture, chest x-ray. Of course, for comfort and to try and get that fever down, you're going to go ahead and give Tylenol. And if it's not responding, you can always add on a cooling blanket. Go ahead and start some empiric broad spectrum antibiotics. Cefepime is our particular antibiotic of choice just for broad spectrum coverage initially at our facility. This next line is a little bit controversial. Consider growth colony stimulating factor. So if your patient is neutropenic and they have fever, GCSF is always, a consideration. 9 times out of 10, the particular manufacturer is going to have guidelines around their recommendations as far as whether or not you should include this in your therapies. And then beyond that, a lot of times it can become provider specific. There is a school of thought that if you administer this colony stimulating factor and then they were having CRS, it could potentially worsen those CRS symptoms. So in our history, we've not actually used the GCSF. We have reserved that for much later on down the road. Of course, with fever, you're going to want to support them. Symptomatic management, again, that's a lot of times just going to be Tylenol. If it's fever that does not respond quickly, then you can even schedule the Tylenol just so that it's being given around the clock. Maintenance fluids. And then this next line, the seizure prophylaxis. Again, this is going to be provider specific a lot of times or center specific and based on your protocols, but we tend to start Keppra prophylaxis on the front end with all of these medications or treatments that could potentially cause CRS. It's just a little bit of extra security to prevent seizures. But if the particular protocol with your program is to not do that, then at this point you would want to add on some seizure prophylaxis. Most of the time that's going to be Keppra, unless of course there's an allergy or other reason that the patient should not take the Keppra. You can consider adding tocilizumab toci for persistent fever or refractory fever. So that's fever that's lasting greater than 3 days. This in general is much mild CRS and is typically pretty easily managed. And if it sticks to just grade 1, it does tend to resolve within, as quickly as it could be just a one-time thing, a one-time fever, a one and done, or it can last 4 to 7 days or even longer, although that seems to be about the average. For CRS management of grade 2 toxicity, you're going to do everything you did on the front end for the fever management, but now you've added on side effects that involve low blood pressure or low oxygen saturation. So with the low blood pressure, of course, a good starting point is always to add IV fluid boluses. If the blood pressure remains low and is refractory to IV fluid, you then would want to consider adding on the tocilizumab. The next line of therapy beyond the tocilizumab is going to be corticosteroids every 6 hours or earlier if indicated. Typically, this is going to be dexamethasone 10. Now, some facilities I've seen do prefer methylprednisolone, but Dex 10 is typically the go-to IV for CRS management. If the low blood pressure remains persistent, at this point, you would transfer the patient to the ICU, start pressors. Most of the time, at that point, you've consulted your ICU team, whether it be pulmonology or if you have a dedicated ICU team, and they're going to manage the pressors. And then, of course, you want to order an echocardiogram. For low blood pressure, supplemental oxygen is needed. So again, this would be binasal cannula, basically hypoxia that's improved with minimal intervention. And then use the tocilizumab with or without corticosteroids, as in with the low blood pressure. So basically, if it's refractory to just binasal cannula, then you can consider adding the toci. And then organ toxicity, that's just going to be your standard symptomatic management of organ toxicity. So for example, in kidneys, if the patients are not eating and drinking well, and because they have fever and just do not feel well, fluids are going to be beneficial there. You can really limit medications that are going to affect the kidneys. Liver is the same thing, managing medications that could potentially affect the liver. And then as far as lungs and organ toxicity, at this point, you've potentially given a fair amount of fluids. You've got patients that are easily thrown into some pulmonary edema. So you can monitor that with chest x-rays and give Lasix as needed, and just do the best to optimize their breathing. CRS management for grade 3 is going to be all the things we've already done, plus additional interventions for low blood pressure. At this point, you are definitely transferring them to ICU. They're definitely on pressors already. If they're on one pressor, you're giving the tocilizumab, you're giving Dex IV every 6 hours. If they're on 2 pressors, you're giving Toci and Dex IV 20 milligrams every 6 hours. For hypoxia, again, everything you've done previously, plus the potential for a high flow nasal cannula, a CPAP, or a BiPAP. Dexamethasone every 6 hours, and if no improvement within 24 hours, go ahead and increase that to 20 milligrams. And then once your CRS grades improve to less than or equal to grade 1 is when you would consider tapering steroids or stopping tocilizumab. So really, you want to see them doing well, and preferably doing well and continuing to improve for 12 to 24 hours before you really consider stopping or decreasing any of these therapies. So CRS management for grade 4. This is when they are having persistent worsening. The low blood pressure does not respond. It's not responding to pressors. It's not, they're to the point of intubation, CPAP, BiPAP. That's when you're going to add on high dose methylprednisolone, 1 gram per day IV in divided doses. So typically we would start 500 milligrams twice daily, do that for 3 days. Hopefully at that point they have started to improve, and then you can begin to taper rapidly. Now, if for some reason your patients have not improved by that point in that 3-day mark, you would still, want to continue to support them maximally. And again, once your CRS improves to less than or equal to grade 1 is when you would consider starting to taper those steroids and the tocilizumab. So the next syndrome is, what is immune effector cell-associated neurotoxicity syndrome, ICANS. So ICANS is a central nervous system toxicity following any immune therapy. It's activated by T cells, NK cells, B cells. Symptoms can range from mild. So mild would be just, a little bit of confusion here or there, to life-threatening. So life-threatening would be just persistent seizures on EEG, unarousable. It can occur at any time, and it can occur with or without CRS, and duration varies from hours to days. Risk factors include age, tumor burden, and comorbidities. A lot of times with CRS and ICANS, the worse your tumor burden is, so the worse your disease is, the larger your tumors, the less responsive they are, the worse both of these toxicities can be. And of course, with comorbidities, if you already have congestive heart failure and are higher risk for fluid volume overload, those type of things can really work against you. So what causes ICANS? CAR T-cell therapy, like we talked about before, BiTE therapies, cytokine release syndrome can cause ICANS, a blood-brain barrier disruption can cause ICANS, neuroinflammation, endothelial activation and damage, and cerebral edema. So assessment. So before a patient is admitted or started on any type of therapy, you want to get a documented baseline neuroassessment, because you can have patients that at their best, they're a little bit confused, or they have some memory problems, or, for example, we had a patient in the past that has received CAR T and he had Parkinson's. So tremors weren't really a good indication of, something's going on, we need to be really watching. So it's good to really, really know exactly where your patient's at baseline before proceeding. And that can even involve as much as going ahead and getting an EEG. So you know where they're at baseline on their EEG, an MRI. And then something else that's really beneficial is going ahead and letting your neuro staff that's on service, whether that week or if you have someone dedicated, letting them know that, hey, this person's getting this therapy, these are their potential side effects, and we may be calling you if they start to have any issues. The most important piece of ICANS monitoring, though, is going to be what's called an immune effector cell-associated encephalopathy score, I-score for short. You're going to start off with getting that every 8 hours. Now, of course, you're not at the bedside getting that every 8 hours because you're not there 24 hours a day, 7 days a week. So this is a really, really good teaching point for your floor staff and nursing staff. And just to help trigger them to be sure that they're doing this, is one thing that we found beneficial is to go ahead and put that in their daily assessment, or, if they're admitted and on the floor, their Q4-hour assessments, just so that it's something that triggers them to be sure that they're doing that. So some things to really be looking at with the patients: if they start to develop any tremors, involuntary twitching or jerking, difficulty with handwriting or other fine motor skills, difficulty naming objects and impaired attention, difficulty performing a movement upon command, altered level of consciousness, seizures, or coma. Obviously, you're going to know that if your patient's in a coma. So that's ideal, is to really, really keep an eye on the smaller, less severe symptoms to prevent the more severe symptoms. So to calculate an I-score, and there's a lot of ways to calculate the I-score. You can do it manually. The computer can do it for you if you have that built into your medical record system. There are apps, and those are really, really user friendly. So orientation, you get 4 points for orientation. The patient is asked to identify the following correctly: the year, the month, the city that they are currently in, and the hospital or clinic that they are currently in. Next, you ask them to name 2 objects, and don't, ideally you're going to pick 2 objects that are pretty easy to name. You're not going to point at the blood pressure cuff and expect them to say exactly what that is in correct medical jargon. So examples can be a pen, a watch, glasses, the remote. And so if they correctly name each object, that's going to be worth 2 points. Following commands. The patient's asked to follow a simple 2-step command. So you can ask them to show you 2 fingers, close your eyes and stick out your tongue, shake my hand, that type of thing. And then before you have ever administered any type of therapy or cells, you ask the patient to write a simple sentence. And so that way you get a baseline of their handwriting. And then with each I-score, you ask them to continue to write that sentence. Now, a note about this: in the middle of the night, when you're waking the patient up for their every 8-hour assessment, and you ask them to write this sentence, first of all, they're probably going to be agitated with you. Second of all, their handwriting is probably not going to be the best because they're half asleep. So if you notice significant differences at this assessment time, you really want to get the patient woken up and determine if it actually is, in fact, a change in their writing. Because 9 times out of 10, it's just that they're sleepy, they want to go back to sleep, and they really just want you to leave them alone. Attention. That's going to get you 2 points, and that's when you ask the patient to count backwards from 100 by 10. So 100, 90, 80, 70, 60, and so forth. So you add all those points up, and it's going to be a score out of 10. With that I-score, you can grade your ICANS. So grade 1 is going to be an I-score of 7 to 9. Grade 2 is going to be an I-score of 3 to 6. Grade 3 is an I-score of 0 to 2, and grade 4 is an I-score of 0. So a grade 1 ICANS toxicity is usually the patient's a little bit confused. Maybe they can't count backwards from 100 by 10s well. Maybe they don't follow the command just right. Grade 2 toxicity is going to be, multiple things within that scoring system aren't quite there. So maybe they can't. Typically, the first thing to go is the counting backwards by 10s. And then from there, patients tend to have difficulty completing their task that you give them or naming things. Grade 3 is when you've advanced to having either an isolated focal seizure or happen to note some edema on imaging, because at grade 3 is when you're going to grade 2 to 3 is when you're going to start doing a lot of your radiology workup to determine if anything is going on their scans. And then grade 4 is when a patient is not rousable. Usually they're intubated, they're having life-threatening prolonged seizures, that's deep focal motor weakness, and then you're seeing some of those changes on imaging, whether it be papilledema seen by ophthalmology or edema on an MRI. So grade 1 ICANS management. First off with this, once you see that a patient's starting to have any issues with their neuro status, you're going to start with diagnostics: MRI of the brain with and without contrast, or a CT of the brain without contrast if the MRI is not feasible. A lot of times these patients, when they're just starting off, they're not so confused that they can't follow instructions, so they're still able to lie still and perform the MRI. But most of the time, patients are agitated, confused, and don't sit still long enough to be able to get really good, clear imaging. If you happen to notice any focal deficits, an MRI of the spine, and then an EEG is going to be really important. And it's ideal to repeat that every day for 30 minutes until you have full resolution of ICANS. So Also, what's important is that on the front end, you've done that EEG so you can compare. So if on this repeat EEG they have any slowing or anything that's concerning, then you can look back and say, oh, well, that is a change, or no worries, that, that's their baseline. You can consider an LP with opening pressure if you're at all concerned about other causes of encephalopathy, like infection or autoimmune issues, leptomeningeal disease, etc. Most of the time, an LP is reserved until later on in the ICANS management hierarchy. With any type of a neurostatus change, go ahead and consult neurology. Increase your ICANS assessment to every 6 hours. You could go ahead and consider an ophthalmology consult to assess for papilledema, but typically that's also reserved until later on down the line. It's very important that you start very, very, very vigilant aspiration precautions, seizure precautions, and some IV hydration, because at this point you're going to make them NPO until they pass a swallow eval. And it's going to be important to really monitor their swallowing from there on out. And then as with any confused patient, they can become agitated. They can be hard to manage. They like to get up out of bed when they're weak and confused and fall. So if they're agitated, you can use low doses of Ativan or Haldol if the EEG is completed, but really try not to use those unless absolutely necessary, because it can also alter your I score. And so then you may have a lower I score and higher grade ICANS than what's truly occurring. On the EEG, if there's no seizures, continue the prophylactic Keppra, which we've already touched on. 9 times out of 10, you've started that Keppra on the front end before therapy as a preventative. But of course, in this particular instance, if you have not started Keppra, do add it at this point. If you find that the patient's having seizures on EEG, go ahead and escalate them to grade 3 or 4 management for ICANS. With grade 1, go ahead and give the dexamethasone 10 milligrams IV for 1 dose, and then monitor clinically to determine if you're going to continue that or not. And then, of course, if it's concurrent with CRS, so if they're having fever, if they have low blood pressure or any oxygenation issues, go ahead and administer tocilizumab. So grade 2 management of ICANS. This is all going to be the same diagnostics as grade 1 with the addition of extended EEG monitoring at the discretion of a neurology consultant. So most of the time, you're not going to get continuous EEG monitoring unless you have transferred a patient to a neuro ICU. So if the patient is still on the floor or in a step-down bed, then you're probably going to stick with just those 30-minute per day spot EEGs. I will say that with ICANS, it seems like patients don't really land in this grade 2 area. You're either a grade 1 and it's minimal, it's just a little bit of confusion, or they've escalated and you're to a full-blown grade 3. So the continuous EEG monitoring is not typically something that comes up and prompts really for you to go ahead and send a patient to the ICU for this. As far as management goes, you're going to continue everything that you're doing for grade 1, but instead of assessing every 6 hours whether or not you're going to give the dexamethasone, go ahead and schedule it for every 12 hours. And then once their ICANS improves to less than or equal to grade 1, then you can start to taper the dex. So grade 3 management for ICANS. Like I said, people typically land on grade 1 and they either stay there or they're going to escalate, and they're going to do it pretty quickly to grade 3. So diagnostics per grade 2 recommendations with the addition of repeat MRI or CT of the brain every 2 to 3 days. If they do have cerebral edema, consider repeating the MRI or CT every 24 hours. And then this is where you would really start considering an LP with opening pressure if you're concerned or are seeing that this encephalopathy is persisting for more than 2 days. So management, absolutely, this patient's transferred to the ICU. Now there it says ICU, but really the preference is to a neuro ICU. If they have any abnormal brain findings, you're going to want to control their blood pressure, correct any uremia, and be sure that all of their coagulopathy studies are corrected well. If there's any encephalopathy or decreased level of consciousness, do schedule the dexamethasone 10 milligrams every 6 hours. So this is an escalation from grade 2 from every 12 hours to every 6 hours. And if they have any grade 3 encephalopathy that's persistent for greater than 24 hours, increase to 20 milligrams every 6 hours. One medication that's going to be different in ICANS management versus CRS management is the use of anakinra. And anakinra in studies has been shown to be more effective in ICANS management than tocilizumab. Tocilizumab really does better for CRS, and anakinra tends to do better for ICANS. If they're having seizures, you're going to want to follow your neurocritical care team's recommendations for seizure control, and then continue dexamethasone 20 milligrams every 6 hours, and don't even consider the anakinra. Go ahead and give it 100 milligrams sub-Q daily. Anakinra is a medication that some facilities have on formulary and it's in stock all the time, and a lot of facilities don't have it in stock and on formulary. So if you're going to be doing a lot of immune therapy, bites, etc., it's a good idea to at least get that first dose on site so that you can start it in the event that you need it. insurance, basically. Better to have it and not need it than need it and not have it. Focal cerebral edema, if it's in the brainstem or the thalamus, methylprednisolone 1 gram per day in divided doses. So typically start off 500 milligrams twice daily, followed by a taper depending on your patient's clinical presentation. If it's other areas of the brain, you're going to go with lower dose methylprednisolone and assess daily and continue to taper depending on the clinical presentation. Of course, as with all the management of any of these syndromes, you're going to start to de-escalate the corticosteroids and supportive therapies, tocilizumab and anakinra, once the patient's improved to grade 1 or less toxicity. So ICANS management for grade 4, it's everything you've done in grade 3. Now, of course, it does say transfer to ICU, but if they're to grade 3, you've already transferred them to the ICU. At this point, you are going to be recommended to intubate them just to protect their airway, because most of the time these patients are having continuous seizures and they're at high risk for aspiration or airway failure. Absolutely, you're giving high dose methylprednisolone and you're continuing that until you see improvement in your patients in conjunction with anakinra, and you're giving the tocilizumab. And at this point, you're just watching and waiting. You're continuing all those therapies and waiting anxiously for these patients for their mental status to improve and be able to extubate and de-escalate these therapies. So a few case studies that I have. We're going to start off with an easier, a little bit simpler one to start, and then we'll have a more difficult one. So first off, we have a 59-year-old male. He has relapsed refractory diffuse large B-cell lymphoma. He's had multiple lines of therapy. That's how he got to the CAR T-cell option. He is currently in a partial response, and he has no additional comorbidities. So on the front end, we've done all of our initial workup. He's had the EEG, MRI, baseline neuro exam. Everything's looking good. We give therapy on day 0 through 3. He has absolutely no symptoms of CRS or ICANS. He's perfect. Vital signs are stable, no fever. I scores are straight 10s all the way through. Then day 4, overnight, he develops fever. Vital signs are still stable. So if you look back at your CRS grading, you know that this is going to put him at grade 1 CRS fever only. So in this patient's case, what we did, we started off with a full sepsis workup. So blood cultures, urine culture, chest x-ray, and escalated to empiric antibiotic coverage with cefepime. Again, your antibiotic choice is going to largely be provider specific, and sometimes providers will opt to add a broad spectrum Marim cefepime in addition to Bank or Dapto. So that's going to be based on your particular facility's preferences. This gentleman's fever was rather sporadic. Didn't really necessarily require a cooling blanket, but we did end up scheduling Tylenol every 6 hours just to control fever and side effects and help him just symptomatically feel better. He ran fever intermittently, on average 2 to 3 times a day for a full 72 hours. And then by day 7, his fever had resolved. We de-escalated him to grade 0 CRS, and by day 14, this gentleman was ready to discharge to the outpatient setting. And in our particular facility, we asked the patient to return daily to the outpatient clinic Monday through Friday for full assessment, lab work, and just to ensure that everything is going as planned. And he did great. He had just a small bit of CRS and carried on and had great response. Our next case study is a little bit more difficult. She was honestly the most severe case of ICANS that I have ever seen. This was a 62-year-old female with relapsed refractory diffuse large B-cell lymphoma. She had seen multiple lines of therapy and was to a PR status pre-CAR T-cell therapy. However, she did have a large amount of tumor burden left and was at high risk for ICANS and CRS. She had multiple comorbidities, diabetes, hypertension, CHF, and obesity. On day 0, we infused the cells, and 12 hours later, in the middle of the night, as always, the patient became febrile. We got the call. We escalated her to a grade 1 CRS and started our full sepsis workup. We added on empiric antibiotic coverage with cefepime, and this sweet lady ran fever nonstop. So she bought herself a cooling blanket and scheduled Tylenol every 6 hours. By day 3, she was very irritable, which with these patients, they're in the hospital, they don't feel well. Irritable is not completely uncommon, but for her, this was very out of character. She was irritable, and then she progressively had some worsening mood changes. That was throughout the day on day 3. By the evening into the early nighttime hours, she became slightly confused. So at this point, we'd escalated her to grade 1 ICANS with an I score of 8 and a grade 1 CRS. So she was already at grade 1 CRS, and now she's at grade or at an I score of 8. Once she was grade 1 ICANS, we did an MRI of her brain. It did not have any acute findings, which was comparable to her MRI at baseline. We did an EEG, which had generalized disturbances, no seizures. Neurology was consulted and they were brought on board. We started seizure precautions, aspiration precautions, and made the patient NPO. We also had already started her Keppra prophylaxis, and we continued that as is and waited on EEG results for further guidance there. She also started Dex 10 milligrams IV every 6 hours. From there, over the next 24 hours, she had rapid progression to grade 3 ICANS with an I score of 1. We escalated her to dexamethasone 20 milligrams IV every 6 hours. Her EEG, initially it only showed a generalized disturbance but no seizures. This one started to have, her repeat had seizure activity, and at that point it was recommended that she start a continuous 24-hour EEG. We transferred her to neuro ICU and consulted neurocritical care team, and they began management for her seizures, which initially her seizures were easily controlled, and she was seizure-free for a majority of the day on day 4. And then later that night, she had worsening seizures, and they became non-convulsive and inducible. So even the slightest bit of stimulation in this patient would potentiate seizure activity for her. So she became more difficult to manage as far as her seizure activity, but our neurocritical care team did a great job of taking care of that, and they were eventually able to control seizures. We, of course, at this point had already started tocilizumab scheduled. She was on dexamethasone 20 milligrams IV every 6 hours. But when she started having the constant seizure activity that were inducible, we went ahead and upgraded her to a grade 4 ICANS with a I score of 0. So at that point, she was clearly unable to protect her airway, and we were forced to ask the ICU team to intubate her for airway management. We did add the methylprednisolone 500 milligrams every 12 hours and anakinra. She remained intubated for roughly from day 4 through day 9. She had grade 1 ICANS throughout that time, as well as an I score of 0. Now, it's obviously very difficult to grade an I score on a patient who's intubated. So basically, if you're intubated and non-responsive, you're 0. Finally, the patient started to turn around and show improvement. And at day 9, we were able to talk to her, assess her, and she did not have any of those inducible seizures. At that point, we were able to de-escalate her to a grade 1 ICANS because she was responsive and her I score was 7. So that was day 9. And fortunately, we were able to extubate her without issue. Her breathing returned to normal very quickly, and she had tolerated her extubation very well. By day 10, we were able to transfer her back to our step-down unit. And at that point, we felt comfortable starting to taper the anakinra, tocilizumab, and the high-dose methylprednisolone. She continued to improve. Now, of course, she was intubated for roughly 5 to 6 days, so she did get very weak. We had to work really, really hard with her as far as her deconditioning, physical therapy, occupational therapy, her eating, her drinking, etc. But by day 22, she was able to be discharged, and that's when we were able to resume normal follow-up with daily visits in the clinic through day 30, which for her, we extended that out a little bit longer just because she had had such a tumultuous experience and had had such severe CRS and ICANS that it was important to just continue to monitor her very closely. But she had excellent disease response to her CAR T treatment, and she ended up doing very, very well. So these 2 case studies are just really a good way to see, it can be as simple as a little bit of fever here or there, or it can escalate much further to full-blown intubation and just, be a very scary time for the patient and their family. So continuing to support them and whatever their side effects may be is really important, just so that you're able to offer that reassurance that this is expected, we know what to do, and we can manage this. All is not lost. This is still very much okay. So that concludes my presentation today. And if y'all have any questions, I will not be available during the actual conference, but my email address is michelle.armstrong@m.org. And if y'all have any questions or comments around this presentation, please do not hesitate to reach out. And I do appreciate y'all taking the time to listen. And if you have any recommendations at all, I'm all ears. So thank you all very much.